Well, hello everybody, and welcome to CE Elevated, a CSU Vet CE webinar series. I'm your host, Dr. Ross Palmer from Colorado State University, and I'd like to thank you for joining us on behalf of CSU Vet CE here at the Translational Medicine Institute. We've named this webinar series CE Elevated, symbolic of our mountainous Colorado terrain, as well as our mission to provide you with an elevated CE experience in everything that we do. We happen to believe there's just great power in the collision between inspired learners, engaged educators, and meaningful experiences. Tonight, we're sincerely thankful for the support of Muvora, who has made this webinar episode possible. Tonight, I'm really excited to be joined by Dr. Don Hulse. Don Hulse graduated from Texas A&M and completed his surgical training at Kansas State University. He then successfully fulfilled the requirements for admission into the American College of Veterinary Surgeons. Don currently splits his time between private specialty practice and his professorship in orthopedic surgery at Texas A&M University. And as most of you know, he's an internationally recognized leader and speaker educator in veterinary orthopedics. Dr. Hulse developed numerous techniques commonly used for treatment of orthopedic disorders in dogs, and is a co-author of the Small Animal Arthroscopy textbook. His clinical research focuses on minimally invasive surgery for joint disorders and for fracture treatment. Tonight, Don's going to be sharing with us his perspectives on the multiple options for the treatment of cranial cruciate ligament disease. If during the presentation you find yourself wanting to learn more, Dr. Hulse and other colleagues will be leading a number of hands-on training courses on extracapsular stifle stabilization, on CBLO, and on TPLO here at the CSU Translational Medicine Institute in the next few months. And so I invite you to check those out at csuvetce.com. So now, without any further delay, I want to turn the session over to Dr. Hulse. Don, welcome.
Oh, thanks, Ross, and thanks for the kind words. And good evening to everybody. Well, could be good morning, good afternoon. I'm not sure where you are, but welcome to this short presentation on different treatment options for cranial cruciate ligament injury. And there's a lot of options, and so we can't cover all of them. But I do want to cover the ones that we commonly teach at the TMI Institute. And so again, treatment options for cranial cruciate ligament injury. And again, there was an article published in AVMA Journal a number of years ago that looked at the different techniques. And there were some 300 techniques described for stabilization of the stifle in the canine with the cruciate ligament injury. So a lot of different options, and there's some that are better than others. The overview of this presentation, we're going to talk about the injury, some of the courses available at the Institute, and then what technique is best for your practice. And that's going to vary depending on your level of expertise, what you've been doing in your practice so far. And then we'll just mention briefly the facility at TMI, the staff, and something just about Fort Collins itself. So keys for successful surgery. Well, the first one is case selection. And there are certain cases that are amenable to any technique, but there are certain cases that only certain techniques should be used, or maybe we should use the word preferable. The knowledge of the internal structures of the stifle are important. And these are topics that are addressed in the courses that we teach at TMI. Diagnostic modalities, just a few points on diagnostic modalities, because there's a reason for catching that injury early in the course of the injury. And then the technique. And technique is proper planning and execution of the technique. And again, these are all things that are taught during the courses at TMI. And then, as important or more important, client communication. What does a client expect from the surgery? What is the postoperative management? And so those things are all very important in part of the discussion. So case selection first. Cases can be managed with a number of different techniques, and a lot of this is going to depend on your expertise. And do you want to start with, if you're not doing knee surgery yet, probably the best place to start is with the techniques that are a little bit easier to learn, and that might be the extracapsular techniques. And there's some things that are a little bit different in today's time about the extracapsular techniques that can make your surgery much, much more successful. There's also client considerations, and this includes finances of the client. Not everybody can go to a specialist. They just don't have the financial means to do so. But if you learn the technique and learn the proper planning and execution, postoperative care appropriately, you can help those clients considerably. And it doesn't have to be a mechanic altering technique. Again, it can be, if you're just starting out, it can be with the extracapsular techniques and doing them properly. So you can help these clients significantly that don't have the financial means to go to a specialist. And there's also geographic considerations. I have the financial means, but the closest specialist is 3.5, 4 hours away, and I just can't do that. Again, you need to, and I hope you do, help those clients with some of the training that's available. So let's look at the internal structures of the knee, and this is probably kind of redundant to you, but the cranial cruciate ligament, and as you can see there, originates from the inside of the lateral femoral condyle, spirals down and inserts on to the tibial plateau. Classically, there's two bands that have been identified, the cranial medial band and the caudal lateral band, named for their insertion on the tibial plateau. The cranial medial band is taut in flexion and extension. It carries most of the load. So a lot of the tears, and my mouse isn't working here, but a lot of the tears originally occur at the insertion of the cranial medial band on the tibial plateau. Now, add to that the function of the cruciate ligament is like ours. It's going to prevent the tibia from sliding forward under load. The difference between the dog and us, because of the standing angle of their knee, is the slope of the tibial plateau. Our slope is about 8 degrees. The median slope in the dog is about 28 degrees. So what that means is every time the dog takes a step on that leg, the knee feels like it's giving way. Whereas with you and I, there's a lot of people that have torn ACLs that do very well without a reconstruction. The dog can't. The dog is just really dysfunctional with an ACL. So it's not only the cranial translation, but with the slope, there's also a proximal distal translation. And that's what makes that dog so dysfunctional with an ACL. We can't forget about the meniscus. A meniscal tear will get your attention. The torn ACL, yeah, when it's tearing, there's pain fibers in there and it hurts. But that discomfort will resolve. The meniscus, that tear will really get their attention. And the reason being, the femoral condyle will catch on that torn meniscus, pull it forward, but it's still attached peripherally to the joint line, and that's where the pain fibers are. So you're pulling on the pain fibers when you have a torn meniscus. And so that's it's very important to look at that meniscus. The function of the meniscus, distributes stress throughout the joint. It's not a focal stress. The meniscus distributes that stress throughout the joint. So different types of cranial cruciate ligament injury that we see in our practice: the acute traumatic rupture. And then there's that progressive rupture, mostly the larger dogs, that occurs over a period of time. The ACL is like a rope, but the cranial cruciate ligament is like a rope, but just gradually tearing over a period of time until it completely ruptures. And then there's what we call the traumatic erosion. These are generally the babies, the juveniles, going to pull off the tibial plateau. So that's the acute traumatic rupture. In my experience, mostly the small dogs the toy breed dogs, but certainly can occur in the large dogs too. But mostly the small breed dogs. And they're very dysfunctional and very unstable with that. Easy diagnosis because they're so unstable. There's typical babies right there, generally the toy breed dogs, and you can see the arthroscopic image there. Just an acute tear. You can see the hemorrhage still there at the tibial plateau. Then get meniscal tears. Now, they are so unstable that generally that meniscal tear is a little bit farther back in the body of that caudal horn than what you typically see. And that's because that tibial plateau is just subluxating so far forward that the tear occurs farther back. The chronic repetitive injury, the one we see mostly in the larger breed dogs, and you can see the arthroscopic image there, and you can see some torn fibers there. That's the origin of the cranial medial band in this particular case. You can see most of it's functional ligament. Clinically, what these dogs do, they go out to the park and they play hard. They're weekend warriors. They go out and they play hard. They come back, and that evening, maybe the next day, they're a little bit sore, but then they're fine. And that process is just going to continue as that ligament gradually tears. Now, why is it tearing? Not a definitive answer. The study I'm showing you here is a study out of Missouri that showed that the blood supply to the core of the ligament in the adult dog diminishes over time. And so when it diminishes, you get chondroplastic change in the ligament, which is less resilient than normal ligaments. So you begin to get some tearing. And then again, that just gradually occurs over a period of time. Here's one here, an arthroscopic image. Now look, see the hemorrhage there and the torn fibers right there? That's the insertion of the ligament, the cranial medial band, the one that's taut in flexion and extension, so taking most of the load on the tibial plateau. And that's where that tear normally starts. And then again, it just gradually continues over a period of time. Now, it's really important to diagnose it at this point, and I'll show you why in just a little while. This is when you want to diagnose them. They're not unstable. There's no cranial drawer on your examination. I don't care if they're anesthetized or sedated, and there's no tibial thrust. You have too much functional ligament. But again, that's when you want to diagnose them, and I'll give you a couple clues as to how to diagnose them here in just a minute. So, breeds at risk. With the Newfies, in fact, there's a gene that has been identified. If the Newfie has this gene, they're more prone to tearing the cruciate. The Rotties, the Labs, Mastiffs. How about the Pitties? Those dogs are all prone to risk. And again, the blood supply in that one study is decreasing over a period of time. The average age is 7 years in these dogs. So it kind of makes sense there. But again, there's a lot of factors that come into play with why this happens. I think mostly it's squirrels. Get rid of squirrels. They just chase squirrels and they tear their ACL. Breeds at low risk. The greyhound, the doxy, the doxy in the basset hound, their slope. The slope in the basset hounds, the normal slope is about 10 to 12 degrees. Doesn't have the same load as the dog that has a 28-degree slope. Greyhound, one study out of Liverpool showed that the collagen fiber in the greyhound was larger than what there is in the Labrador. So those breeds are at low risk. And the small dogs, I think they're more acute. They can have this partial tear. They can have the same thing, but they're generally more of an acute risk. And here's the babies, the other one that we see. And you can see the different presentations there. The one on my far left, where you have a nice substantial piece of bone pull off the plateau. The one next to it there where it's pulled off the plateau, but it's fragmented. Very rarely you see one where it pulls off the femoral side. You can see very unstable. The femur's living in the back. He's totally subluxated. And then rarely, more rare than that, you get a complete rupture. So that's the baby. So keys to success. You got to diagnose it, and I'll show you some modalities there. The cranial drawer test. And here's one here, and you can see very, very unstable. This is a larger dog with an acute tear. Doesn't happen often, but you can see the acute tear. Now, one thing about the tibial compression test, and here's a tibial compression test here, as you saw in some of those images, when you injure that ACL and it's a complete tear, the tibia is fixed in the forward position. So if you're going to do a drawer test or you're going to do a tibial compression test, make sure you push the tibia back first. If the tibia is already forward, then you can't push it any farther forward. So in that drawer test and the tibial compression test, we're going to push the tibia back first to get it in the reduced position. Then we're going to do our test. Now, I think this is important here. And this is what's called the sit test. And Barclay Slocum, he's the one that actually described the sit test first. But what he described was a little bit later. What he described was when the dog begins to sit, they'll turn their knee to the outside. And that's very, very true. The reason they turn their knee to the outside, they can't flex. There's too much fibrosis in a fusion. So they turn their knee to the outside. But that's later in the process. This is what I want you to look for right here. Look at the image on my left anyway. Dog normally sits. And part of your exam should be, let's get the dog to sit. Can't go side saddle, has to sit in that straight position. But don't look at the knee. See how the knee's flexed up in there? Right up underneath him. But look at the ankle. Look at the tarsus. Flexed up in that sphinx position. Now, look at the other image over there. The knee's flexed up. It's not turned to the outside, but look at the ankle. They don't flex the ankle up all the way. That's a very early abnormal sit test. And in that large dog that has that ligament injury, that early ligament injury, that's, in my experience, that's almost pathognomonic. And I think there was a paper out of England that kind of substantiated that. So abnormal sit test, effusion. And again, my mouse isn't working, but look at the image on your left. Now, most of the time we look at the front of the knee, we look at the fat pattern, and that's very diagnostic. It should be a nice dark triangle there, but look at the back of the knee and look at the normal, and that's the image on my left. Look how close, there's a dark line running vertically right behind the joint. Well, that's just fat right behind the joint capsule. It's close to the tibia. And more importantly, there's some little tributaries, dark tributaries that come off of it going towards the center of the joint. That's normal. Look at the other image there. See how that line's moved back away from the tibia? And more importantly, you lose all those little tributaries. That all becomes homogeneous in nature right behind the joint there. So abnormal sit test, abnormal imaging, that's an early ACL. No instability that you can detect in these dogs, but that's when you need to diagnose them. And we'll show you why in here just a minute. So techniques and proper planning and execution. The techniques that we teach at TMI, extracapsular, and that might be the one if you're just starting out because of financial considerations, maybe ease of learning the technique, that may be where you want to begin. And there's certain cases that particular technique is probably not the best technique. So that's, if you want to advance, if you're already doing extracapsulars and proficient in that, you might want to consider learning some of these other techniques. And one is the TPLO, which everybody's familiar with, and there's one called a CBLO. Certain advantages for each one of those techniques, which we'll try to address if we have time. But that extracapsular technique may be the one, if you're just starting out learning knee surgery, this may be the one that is the technique that can be used in, I would say, 90% plus of the cases. So the financial investment, is not as great as some of the other techniques, and it really is effective. Now, there's some differences in the way we teach it today relative to the traditional technique, and I call traditional technique the nylon crimp technique around the fibula to a hole drilled in the tibia somewhere near the insertion of the patella tendon, and that's what that turquoise line is. Now look at the graft over there, and look at the difference in distance between those 2 points as you go from flexion to extension. It just can't work. And so what we teach is the more what we call quasi isometric point. There's no true isometric point, but we can get pretty close. Look at the blue icon there. And that's what we call the F2T3 site. And that really is effective and works in small dogs, medium-sized dogs, even large-sized dogs. Large-sized dog, you just put bigger material in there. And so that's one of the things that one of the techniques we teach at TMI. This is just some work here that showing that there's the intact. You see the graph there, the intact, and this is cycling. And then you look at 10 hours, after 10 hours of cycling, about the same. One of the important things is having bone-to-bone anchorage. You don't go around the fibula. You don't have soft tissue that can stretch out. So it's bone-to-bone anchorage. And again, technique that we teach at TMI. One of the other techniques is called the CDLO, probably not as well known as the TPLO, but a good technique. Advantages with that technique that where you can't use a TPLO. And so there's some advantages of this technique. There's advantages of the TPLO technique too. And just what we teach in the course is how do you determine the location and the magnitude of the core, and then proper execution of the technique. So again, if just a little bit of an advanced technique that is very helpful in a lot of circumstances where you can't use, or maybe not the preferable technique, the extracapsular technique, or even maybe a TPLO. So proper execution, and we'll teach all that. Now this is the TPLO, and everybody's familiar with this. It's been around since actually 1983. Barclay Slocum developed this in 1983. How do you measure? How do you execute it? That's what we teach in the courses. A lot of these, particularly little dogs, may have a patella luxation. In addition to your cranial cruciate ligament injury, every one of these techniques that we teach, the extracapsular technique, the CBLO, the TPLO, you can manage the stability and gain stability, manage the instability, I should say, and gain stability, as well as do the techniques that you need to do to stabilize that patella and keep it within the trochlear grip. So you can do both of those techniques coupled together. I can't forget, just one image here, and we teach this, we emphasize this. How do you examine the meniscus? Because again, that meniscal tear will get their attention. And if you miss that meniscus, they may, instead of being in the excellent category, they may be in the good category, or maybe even worse than that. So one of the things we emphasize in the courses is how do you view the meniscus? And the meniscus is going to tear. It's the posterior horn, or the caudal horn of the medial meniscus, the most difficult part of that joint to visualize. And so we teach, how do you do that? How do you look at it? How do you examine the meniscus, and how do you attend to the meniscus if there's a meniscal tear? Very, very important with your stabilization technique. So another image there. So now we're going to pause, Ross, and see if there's any questions.
Yeah, thanks, Don. That was great information. Yeah, there's a few questions. One is, you mentioned about these different types of tears that occur. I think you referred to the acute traumatic, you referred to the degenerative tear, and the traumatic avulsion in the juvenile patient.
Mm-hmm.
How do those, the question that was asked is, how do those affect your treatment recommendations? And I'll just jump in on one of just kind of things that jump through my mind. But so, taking, for example, that traumatic juvenile avulsion, that presumably is a patient who has actively growing physes. And that's an area where I can remember some years ago, a patient where I did an extracapsular repair, and that was probably not the thing to do because my suture was preventing the growth of that physis. And so the suture got tighter and tighter and tighter, and probably iatrogenically created a patellar luxation. And so that's just one example of how the type of tear might impact our treatment recommendation. What thoughts do you have in response to that question?
Yeah, you're exactly correct, Ross. With the juvenile, and we're seeing more and more of these now. And I'm not sure exactly why we're seeing more and more, and not just the elite athletes. We certainly have always seen them in the elite athletes that are undergoing intensive training when they're 5 months old, 6 months old, in that range, but also in the pet, because they're just weekend warriors, and they can tear their cruciate. Now, and what you mentioned is spot on. You can't do an extracapsular technique because your suture crosses the growth plate, and it's basically increased pressure on a growth plate. You decrease growth, what's called the Hutter-Volkmann law. You decrease growth, you decrease pressure, or you increase pressure on the growth plate, you decrease growth, you decrease pressure, you accelerate growth. So in the femur, over on the suture generally on the lateral side, you're going to end up with a valgus deformity of the distal femur and probably a lateral patellar luxation. Some of the other techniques are the TTA, the TPLO. You cannot use those techniques in a 5-month-old dog because you're cutting through the growth plate and you're going to create a deformity. And a lot of people with those kind of injuries will say, well, come back when you're 9-10 months old, and we'll do whatever our favorite technique is, TPLO, extracapsular stabilization, TTA. The problem with that is, during that period of time, well, two things. If it's an elite athlete, that period of time training is extremely important in training that dog properly. If it's a pet dog, a weekend warrior, well, it can't be weekend warriors for 6 months or whatever. So the technique that I prefer is that CBLO procedure, because the osteotomy and the stabilization is distal to the growth plate. So you don't affect the growth plate. They can have normal growth and you can stabilize that joint. There's other technique, cranial closing wedge osteotomy would probably have the same effect. Those are the only two I think you could use in a juvenile dog that's 5 months old that has a cranial cruciate ligament injury. And we do prefer to stabilize them at that point. In fact, we're going to do a primary repair of the ligament, so they have a ligament for life.
So
we're going to protect that repair with that leveling osteotomy.
So I bet you're probably going to show an illustration of a CBLO and how it doesn't span the physis and such. I know that's coming up. I think as well, I think one of the things we all hold true is with any of these techniques, one of the keys is absolutely case selection, right? And so yeah, I think that would be one of my pieces of advice for anybody who is watching this evening or watching on the recording is it's not just learning the technique. I mean, that's really important. You have to do the technique properly, but the other thing you've got to do is you've got to select the right technique for the right patient. So that needs to be a key part of the training without a doubt.
Right.
This next question is a great one. It's about the importance of visualizing the meniscus, and again, an important aspect of the training. But the question comes up is it important to actually open the joint to look at the meniscus? What's your comment on that, Don?
Yeah, and there's two schools of thought there.
Yep.
There's certainly a camp that says, we're never going to open up the joint. My opinion is, yes, you do. Whether you do it arthroscopically or whether you do it with an open arthrotomy or mini arthrotomy, you have to look at that meniscus. Again, that meniscus will get your attention. Now, what's going to happen over a period of time is going to get your attention, yes, for a period of time, but it's a bucket handle tear. So it's attached axially and at the peripheral margin. Generally, what happens over a period of time, one of those attachments will release just from pull by the femoral condyle. They get much better clinically when that happens because you're not pulling on the joint line as much. But that meniscus still trapped between the femoral condyle and the tibial plateau. And I have seen, and I'm not talking about many, many cases, but just arthroscopically on second looks, you'll get a very significant articular cartilage lesion, even divot there, where there's no articular cartilage in a divot, where that meniscus was trapped between the condyle and the plateau. And those dogs, as I said earlier, they may be in the good category post-surgery rather than excellent category. So my opinion, yes. Just look at that meniscus. If you have a bucket handle tear, remove that bucket handle tear.
Yep.
If it's a normal meniscus, then you have the whole thing about meniscal release, and some people believe in it, some people don't believe in it. And everybody has their own opinion. I know from second looks, as long as 5 years post-op, arthroscopic looks, a meniscal release doesn't seem to have an adverse effect on the cases that I've seen. So if I have a dog that's 10, 12 years old, I may do a meniscal release. But if I have a dog that's 3 years old, I'm not going to do a meniscal release because I don't know what that will look like 8 to 10 years post-op.
But I would echo your statement of, I think visualizing the meniscus is a valuable thing to do, and that's an art, isn't it? That really is an art through an arthrotomy and arthroscopically as well. But when we're teaching people through the arthrotomy, those are the things it's hard to learn in a textbook because there is a real art to how the knee is positioned, where your distractor is positioned, etc. And so that is a key aspect of the training.
And I think one of the keys we emphasize in the courses, how do you look at that caudal horn of the median meniscus?
Absolutely. Well, I think that does it for questions for now. I'll turn the second half of the program back over to you, Don, and then we will have an opportunity for questions and answers at the conclusion of that. So please feel free to continue to put your questions in the Q&A window, everybody. Thank you, and take it over, Don.
So, technique of choice. What is best for the patient and what is best for my practice? And these are the techniques, again, we normally teach at the TMI Institute. I think there's a number of considerations here. What's your patient population? Are you seeing mostly larger dogs with the torn ACLs? Or is your population the smaller dogs? Both of those populations are amenable to the extracapsular technique, and maybe that's where you should begin if you're new to knee surgery. And of course, you have an interest. It depends on how keen your interest is and how much time you want to devote to it. Each one of these techniques for proper execution and planning, there is a learning curve. It's not an extensive learning curve, but there is a learning curve, and you have to do it properly and pay attention. So you have to have the time and interest to put into that learning curve. And there's a financial consideration. If you do one of the mechanic altering techniques, whether it's TPLO, CBLO, there's more of a financial investment in those two particular techniques. So again, maybe you'll start out with the extracapsular techniques, execution proper, looking at the meniscus proper, and you'll have really, really good results. But there are some cases that maybe that's not the preferable technique. And as you're going along and getting more experience, and you want to go to that next level, CBLO or TPLO. And there's nothing magic about either of those techniques, although I will say, and I did TPLOs for 10, 12 years. I do mostly CBLOs now. Gosh, I was scared to death to cut the bone. And so there is some hesitation there, but there's no magic there. Those techniques are really very learnable. So let's just go through some of the different scenarios here. The large active dogs in the giant breech. I think most people are going to prefer a mechanic altering technique, whether it's a CBLO, TPLO. But I will say this, that with proper execution of the quasi-isometric or the isometric points and bone-to-bone anchorage, the extracapsular techniques have worked well in my hands. And when do I do that? Well, there's some clients, again, well, I don't want you to cut my dog's bone to fix his ACL. Or the mechanic altering techniques are more expensive. There's no question about that. And some people just say, I just can't afford that. Is there anything else you can do? Yes. So that extracapsular technique can work in that larger breed, in that active dog. We talked about this. Remember, abnormal sit test, that effusion, early tear. And if you look at the arthroscopic image there, that's an insertional tear of the cranial medial band on the plateau. 90% of the ligament is functional. We know from second looks on both TPLO and CBLO, if you modify that plateau, you take the stress off that functional ligament and it doesn't continue to tear. And those joints look absolutely pristine and functionally pristine long term. So if you have an early tear, preferably again, modify that plateau. That's the next step now. That's beyond that extracapsular technique. But again, no magic to it. And the juveniles. There you can see the planning for a juvenile. He's pulled the ACL, I use ACL, the cranial cruciate ligament off the plateau, and you can see the arthroscopic image there. We're going to do a primary repair. We're going to suture that back down to the plateau. And then we're going to protect that with modifying the plateau and taking the stress off of it, just like we do with that early ACL. And if you look at this one image, this dog is 4 years post-op. Not an elite athlete, but certainly a weekend warrior, like a lot of them are. And this dog is absolutely stable and functions normally. The other thing, don't have a lot of evidence base here, hadn't torn the other side. So maybe if we give them a really good knee on the side that's injured, they won't tear the other side. No evidence base there, just empirical information. Dogs with excessive plateau. Look at this dog here. You see the measurement of the plateau. He's got a 50 degrees plateau. And can you do a suture? And I would do a suture if the client just cannot afford anything else, I still think you can help them, but not preferable. Modify that plateau. That's what most of us say. And again, if you have some experience, go to that next level. Learn how to do a TPLO or a CBLO. Let's look at the facility itself. The TMI. It's Wayne McElraith. Most of you probably know. Maybe not large animal surgeon, but very, very nice person. And he got the funding to develop this educational facility. It is amazing. That's when you first walk in. It's 3 stories. It's dedicated to education and research. The classrooms and the imaging in the classrooms are unbelievable. And the technical staff is unbelievable in helping with all of that. So that's one of the classrooms. There's one of the other classrooms there. The laboratory, it's where we do the techniques on cadavers, generally on cadavers. It's most often a combination of the saw bones, the plastic bones first, and then you take that information and take it to the cadaver. But the equipment, the facility, the imaging is just outstanding. We generally do demos on whatever procedure we're doing first, and again, the imaging and the video recording is just amazing there. So great facility. And of course, the faculty is great. You recognize Ross there. Dedicated to education and very, very experienced in education, as well as every technique that Ross is teaching there. So great facility. Oh, in Fort Collins, nice place. I don't like it much in February when it's cold, but being from Texas, but just a great place. Old Town Fort Collins, a number of boutique restaurants and bars, just a fun place to be. So would encourage you to look at that. And I think this is the last slide here. Oh, these are my puppies.
Good morning. It's great to see you. Good morning.
11 of them.
Good morning to you. Good.
And then there's a puppy there, a little bit older.
It's great to see you.
So, anyway, that's the end of the presentation, Ross. Happy to answer any questions.
Well, thank you for those kind words about the facility and the area. It's funny, as a Texan, you say you don't like it here in February. I notice when I go to the ski resorts, you may be the only Texan who doesn't like it here, because we certainly have a number of them that time of year. But anyhow, that's a side note. So, couple great questions have come in. First two are a little bit related to one another, and so I'll do them in tandem. But the first one was, is it important to confirm via palpation and visualization that it is a caudal cruciate, or that it's a cranial cruciate tear? So is it important to confirm that? And then this ties in kind of the second question, very related. What would happen if you did an extracapsular stabilization or a TPLO or a CBLO in a dog that had actually an isolated caudal cruciate tear? So it gets back to that question: is it important to know what you're treating?
Yeah, absolutely, no question. It's important to know what you're treating. Now, those very early tears that we showed, not likely to be a caudal cruciate, but certainly can be, and it's easy to confuse a caudal cruciate with a cranial cruciate because both of them prevent cranial caudal translation. And so it's sometimes difficult to say, well, wait a minute, is that caudal translation or cranial translation? And I will say, starting off, that isolated caudal cruciate ligament injuries are not common. They do occur, but I'd say they're going to be less than 3% of your cases. Now, that doesn't say don't go in there and look, but you're going to look before you decide what management you're going to use. So if you look in there And the caudal cruciate ligament's been divided into bands here recently within this year in the cranial medial band and caudal lateral band. The cranial medial band is the one that takes the brunt of the force with the caudal cruciate ligament. So you're going to go in there and look. You can see the caudal cruciate ligament and see if it's torn. Now, what do you do about it? Let's just look at caudal cruciate ligament. What do you do about it? There's a lot of people that say just it's going to do fine. And I think with conservative treatment, you're not doing anything. It's not under the same load. You don't get the same degree of translation with a caudal cruciate ligament under weight bearing load that you get with a cranial cruciate ligament. So a lot of people just leave it, debride it, and leave it. And I think for the average pet, I do believe those cases do extremely well. For the elite athlete, what we're doing today is we're replacing the caudal cruciate with an intra-articular graft. And that's just in that elite athlete. So it can be difficult, but you're going to look. And if you have a caudal cruciate ligament, of course, you're not going to do a CBLO or TPLO. You can do an extra cap, but you put your extra cap running in the same direction as the caudal cruciate ligament rather than running in the same direction as the cranial cruciate ligament. So that you can stabilize that with an extra cap. It's just kind of backwards compared to a cranial cruciate ligament.
Yeah, I wholeheartedly agree with you you see so few of these isolated caudal cruciate ligament tears that it's just enough to bite you in the rear, right? Because you don't want to do a TPLO or a CBLO or a traditional X cap in those cases. And so, sometimes you can tell via palpation, sometimes you can't. We kind of talk about that in these courses. And then again, that importance of really knowing your intra-articular anatomy, knowing it inside and out so that when you're looking inside the knee, you know what you're dealing with and you're not going to be that guy or that gal that did the wrong thing. Yeah. So great information. Here's another, go ahead.
And I would just add one thing, Ross. Most of the caudal cruciate ligament injuries or deranged knees, where you have caudal cruciate, you have cranial cruciate, you have collateral, you have meniscal injuries. That's not the one you want to start with.
Yeah, especially in those cats, we see that one. But yeah, whether it's a dog or a cat, I totally agree. And that gets back to case selection. Don't start there. That's not your friendly. Yeah. Next question was, and it's got a preamble to it, but it says, I was taught that good places to do extracapsular stabilization is in the highly unstable knee with a complete cruciate tear, presumably cranial cruciate, small dogs, and dogs that have lower performance expectations, and possibly older dogs. That's where I was taught to do it. When would you recommend I not do an X cap?
Well, I agree with every comment that was made there when you can do it, but I will add to that, again, depending on geographic considerations and financial considerations, you can still help those dogs significantly. I don't care what kind of dog it is, with a properly executed extracapsular technique. Now, when would you not want to do it? Well, maybe that excessive slope. With that early tear, if you modify the plateau and that ligament remains functional, we don't have the evidence base, even with the newer extracap techniques. We don't have the evidence base that would suggest that extracap technique would protect that ligament long term. So again, with those early ones, I want to modify the plateau. With an excessive slope, probably want to modify the plateau. But in my mind, an extracap technique properly planned and properly executed, and you attend to the meniscus, it is a very effective technique.
Okay, great. And looking here, I don't think I see any other questions. And so I do want to thank you, Don, for an outstanding presentation and excellent information. We certainly appreciate your willingness to contribute to this CE Elevated webinar series. Also want to give a huge shout out to Movora for sponsoring this evening's webinar episode. And as a reminder, Dr. Hulse and colleagues of ours will be leading a number of different hands-on training courses on extracapsular stifle stabilization, also on TPLO and on CBLO here at the CSU Translational Medicine Institute in the next few months. So do feel free to check those out at csuvetse.com. Once again, I'd like to thank all of you for joining us this evening. Next month, we'll learn about how you can use fracture treatment training to save limbs and save lives of your patients. I'll be presenting that particular episode on Wednesday, April 6th at 7 p.m. New York time. That's 5 p.m. here in the mountains, and we'll look forward to seeing you then. In the meantime, remember, you're more than a learner, you're a whole person. So take care of yourself, and let's look out for each other. Have a great evening, everybody.